to.
Just prove it.
I said used to be able to. Yeah.
Go get a.
I can't. I have swallowed fire. I have. Are we ready? Okay. Welcome everybody to the Children's Hospital. We're glad that you're here today. If you're joining us on streaming video, we appreciate you joining us. We are in the business of saving lives here at OU Medical Center, and this is a case in point right here, where thanks to the before and the during and the after teams and a concerted effort, we were able to identify a problem while the child was still in the womb. We were able to take care of that problem when the baby was born, and afterward, a few days afterward, whenever we were actually able to go in there and perform this awesome surgery that we're going to tell you about today. It's called transposition of the great arteries or vessels, and it's pretty amazing, and I will let the doctors explain what it is more than I, the layman, but I can tell you it's basically rerouting the plumbing in the heart so that the blood flows in the right direction. But it all starts at the very beginning by identifying the problem. And I'm going to introduce to you our physicians and our family here today. This is Dr. Harold Burkhart. He is a pediatric cardiothoracic surgeon, and he is fairly new to the Children's Hospital. This is Dr. Marvin Williams. He is a high-risk pregnancy physician. This is Whitney Carter, Whittney, Carter, common spelling, and she's the mom. This is the brother, Weston. He's involved in the family process, but not the star of the show today, although he may end up taking some credit. This is Dad, Rory, R-O-R-Y, Carter. And this is our little star, Levi, L-E-V-I. He's 2 months old, and he was born January 27th. And wow, what a journey it's been. And I'll let actually Dr. Williams start off today to kind of bring us from what happened whenever Whitney presented herself as a patient to him.
Thank you. Whitney, the Carters, presented to our clinic in transfer from one of the local obstetricians because of concerns for a heart defect. And when we met Whitney, we performed what's called a level 2 ultrasound or a targeted ultrasound to confirm what in fact was the case, transposition of the great arteries. Whitney and her family actually presented to our clinic service knowing a lot about the disorder or the complex cardiac defect. But I think what was important from our standpoint was when we finally assumed her care, which was close to term, 37 weeks gestation, or about 36 and 5/7 weeks, so a couple days shy of term. And in doing so, we had to, you do great work, Dr. Burkhart, you do great work. And in doing so, we had to quickly mobilize several services, our pediatric cardiology team, our pediatric cardiothoracic service, as well as our neonatal intensive care unit service, and our labor and delivery service. So in just a matter of just a couple short weeks, we were able to mobilize all of our services and have a wonderful outcome.
Dr. Burkhart, talk a little bit about what the condition is and how you essentially replumb the heart.
Okay, well, kind of like what Scott said, it's replumbing and rerouting the heart. Transposition is, it occurs maybe about 1 out of 2,000 births. So it's relatively uncommon, but it's a fairly common neonatal big heart surgery that we perform. And what happens is there's 2 pumping chambers in the heart, the right ventricle, which pumps blue blood to the lungs, and the left ventricle pumps oxygenated or red blood to the body and the brain. And in a baby born with transposition, the blue ventricle is pumping blue blood to the body and the brain, and the red ventricle, the left ventricle, is pumping red blood or oxygen blood to the lungs. So there's 2 series. There's one ventricle pumping blue blood to the body, coming back blue, and just keeps pumping blue blood around. And then there's another pumping chamber that keeps pumping blood to the lungs, gets oxygen, and then keeps pumping it back to the lungs. And so with that sort of circulation, if you don't have a connection to where blood will mix, a baby will not survive. And if they don't have their ductus, an artery open in the heart that allows for mixing as well, the child won't survive. So a baby with what Levi has, if he was just not taken care of and it wasn't recognized, he could be in pretty bad situation within a few hours, and even sometimes after a couple of days. So it's a big deal, and it's considered a life-threatening cardiac anomaly in infants. And so that's the beauty of what's happened with his case, is that we knew ahead of time, and Dr. Williams and his team were all set up and got 100 other people involved with all the teams, so that we could get all the right people to help deliver the child, to help with the pregnancy, help with the delivery, help taking care of mom after the surgery, but help taking care of Levi after the surgery, and making sure he's on the right medicines and that he gets stable until he gets into my hands and has a surgical repair. So before I even see him and do the operation, there's already been a lot of people doing a lot of things to ensure that everything looks good for both mom and Levi. With regard to the surgery, it's open heart surgery. You divide the breastbone, and open heart means you go on the heart-lung machine. So I put a tube in his heart that takes blue blood to a machine that gives it oxygen, brings it back so that his brain and his body has oxygen, while I stop his heart and do the repair. And I stop his heart, and the repair, when I explain it to families, sometimes they think, it sounds pretty simple, because sometimes it sounds pretty simple to me when I talk about it. I say, well, what we have to do is we have to take these two arteries, we have to divide them from the heart, mobilize everything, and then switch them over. So it's called an arterial switch. You're switching the arteries. And so the artery that's going into the lungs, to the ventricle that has the blue blood, so it'll get oxygen, and the artery that's going to the body and the brain to the ventricle that has the oxygenated blood. So that's called an arterial switch. And that part is pretty straightforward. Those arteries are maybe the size of my little finger, or maybe 5 millimeters or so. They're okay. But the problem is with that operation, as I explained to mom and dad, after you do that, then you have to bring their coronary arteries along. And the coronary arteries, if you recall, are the arteries in adults that get blockages and have to have stents and stuff. But in Levi, they're about 1 millimeter to about 2 millimeters in diameter, so about the size of the lead of a pencil. And so that part ends up being kind of the delicate part, because you do have to cut those arteries out of their origin and mobilize them enough to sew into the new artery. And that's always kind of when we release the clamp and let the heart beat. We want to see the heart go into rhythm right away and get blood in their arteries right away, because then we know there's no kinks in the arteries and that they've been sewn in okay, and there's no blockages or anything. And with Levi, that's how it went. He actually did phenomenally well from a surgical standpoint. His heart came right off bypass. I think it went fairly quickly. I was talking with you, and I think I still ended up eating lunch that day, so it had to have been a pretty quick operation. And he did, I think for the most part in the ICU, he did remarkably well. I mean, he was working on some feeding issues and that sort of thing, but he's done great. And now you can see one of the signs of this anomaly, as well as a few other anomalies, is that a baby can be born blue because they're not getting enough oxygenated blood. And you'll see when you take pictures of him, or you're looking at him right now, he's a pretty pink baby, so we know everything's routed right, so the plumbing, as Scott alluded to, is set right. And the good thing about it is he should be pretty much able to act like a normal kid and act like his brother and wrestle with his brother and grow up just like his brother.
Can you talk a little bit about, how you learned that you were carrying a baby that had some issues and what that process was like for you?
I remember going in to find out what I was having, and I was told at that time that they were confirming the transposition of greater arteries or vessels. And I just tried to hold it together while he was explaining to me a little bit what it was. And then as soon as, you get out of the doctor's office, you're just trying to take it all in. And then we just kind of talked to, friends and family, and kind of what I call Google search, just a little bit, so I wouldn't worry myself too much. Because I did want to talk to the doctors and had a lot of questions for them, because I want to go straight to the source, not necessarily just read online, like certain blogs and such like that.
Dr. Williams, what do you tell a mom like that who finds out that their baby is in this type of thing?
Right. So I think the most important thing is that whenever we diagnose something like this in utero, is that we weigh all of our options and we, again, mobilize the team necessary. I think Dr. Burkhart said it well when oftentimes, although this is a potentially rare cardiac or heart problem, the problem with it is that if it's not recognized, that these babies can get sick very quickly. This is what we call a cyanotic heart lesion or defect. So although this is, like I said, a relatively rare diagnosis, it's even, we tend to unfortunately miss this diagnosis at times. And in doing so, you can see that the outcome, you could potentially see that the outcome would be catastrophic. So we were fortunate that we were able to confirm this diagnosis and, more importantly, be at a tertiary care center that provided all of the experts that could quickly be mobilized so we could have a wonderful outcome like this. And I think also a testament to the Carters is just, again, meeting us so late in the game, if you will, and bonded almost immediately, and allowed me, I was fortunate enough to be part of her care and assume her private, obstetrical duties and delivered Levi on the 27th, and that went incredibly well. So I think all in all, this is a win for everyone all the way around.
How's Levi doing now?
Great, a normal baby. He squeals. He has a very high-pitched scream. I think all the nurses, when he was in the ICU and NICU, said it was the most screeching scream they've ever heard. So he has to fight because of his little brother here. He's got to get all his attention. So.
Going back to the day where you went to the doctor's office and he told you about Levi's condition, and as you were leaving, were at any point in that time were you scared that you were going to lose your baby?
No, I wasn't, because I knew that while he was inside, he was okay. It was just once he got out and started breathing our air would be the problem.
Can you talk a little bit, there is a process that happens normally in the body with the baby that you had to kind of keep from happening, correct? That is the process that allows the blood to mix.
Right, there's several shunts that allow, so in utero, like Whitney said, whenever the baby's umbilical cord is clamped and cut, he or she they take their first breaths, and the lungs and everything have to work in order for that transition from in utero to ex utero life or being born. In utero, the placenta functioned, if you will, as the lungs, because oxygenated blood is transferred from mom to baby. So the lungs don't receive a lot of that blood because of various shunts. So when babies are born like this, there's one shunt in particular called the ductus that we have to keep open with medications until someone like Dr. Burkhart can perform surgery in order to keep that mixing or that oxygenated and deoxygenated blood. Because without that, this, like I said before, is cyanotic lesion or a defect that can cause the baby not to do very well at all.
How quickly after the surgery, they talked about how remarkably everything went, and how quickly did you notice a difference and see him doing well and being that little baby that you were expecting?
Pretty much when he came out, his scream, really, you got to hear it and it was normal like his, and, I guess the cardiac pediatric team that was caring for him, brought him over to us and said he was doing a lot better than what they had expected. And that's when, we were just ready to get up to see him in the NICU.
Does his brother understand what's going on?
No, We didn't bring him to the NICU just because he's more interested in all the lights and the buttons. Yeah.
Okay, you guys seem relatively calm now. Granted, it's been a couple months now. Were you this calm throughout the process, or what was going through your mind?
I believe we were. I mean, you just kind of have to take it just as it comes. You don't really have time to, I guess, sit there and just dwell on what has happened, because he is here and he had wonderful care and we were very confident in where he was. So I guess once you have them and go through it, you just get this calmness about you. And we had confident surgeon, doctors, so we were very happy.
So, Rory, what are you thinking as a dad during all of this?
It's hard enough to find time to think. Like she said, just work. That's all I can do. We still gotta keep our life going. So, like I said, he had the best care he could have, and he's here with us now, and he's doing great. So.
When you look at it, I mean, do you think about it?
Oh, all the time. Every time I see it, but. Every time I see that scar, I think of the great doctors and everybody that saved his life. So that's always a good thing.
Doctor, what are some of the challenges now that will be in Levi's future?
Well, I think for the most part, everything looks good for the future. In babies who have transposition, probably anywhere from 8 to 12% of them in their lifetime will need something done to their heart from a surgical stent or a balloon standpoint in the cath lab, but that will be typically relatively minor compared to what he's gone through. That said, 85% plus will have, go on with a 4-chamber heart and live a normal life. So I think the main thing is just to continue following up with their pediatrician and the cardiologist. They'll probably get an echo once a year, an ultrasound, to make sure the heart's developing and growing properly. And the majority of the time, that's what happens.
So possibly as a teenager, you wouldn't even know that this even happened?
No, there's a lot of kids that have had arterial switches that, playing sports, you see at picnics or whatever with other patients, and you would have no idea that they had, because essentially now they have a normally functioning heart. They still have 2 pumping chambers like you and me, and they still have 2 collecting chambers, and this is one of those operations that's a great operation, because once you fix it, they have about as normal of a heart as you can have.
And then I'd like to get your thoughts. I know you're probably very humble about your line of work, but I mean, you could be considered like the top gun of surgeons. I mean, you'd have to have a special art and talent to be able to operate on a newborn.
Yeah, that's what Dr. Williams always tells me. And, no, there's a lot of training that goes with it. I had 6 or 7 years of general surgery training, then 3 years of cardiothoracic, in addition to another year of pediatric heart surgery. But we always say that the group of us that do this it takes a lot of training to get to where families can feel comfortable giving you their child to stop their heart and do an operation. So it's technically demanding, like a lot of surgical specialties, and it's stressful like a lot of medical and surgical specialties, but it's extremely satisfying that we're able to.
Levi's heart when you go for it?
In general, probably like a small plum or a big walnut, something like that, and again, but that's about what it is.
Do you ever stop and just kind of go to the magnitude of it all? I mean, when you're holding that little heart in your hand like that, just kind of go, wow.
Well, I think I try to avoid stopping during the operation. I try to be focused and keep going, but it is a good thing, and it's great that we're able, as a hospital and a group, to offer this to somebody. And this is a true testament to how heart surgery in children should be this day and time. We should have teams like Dr. Williams' team and all these teams coming together and not having babies like Levi out in the middle of nowhere in a bad situation and potentially dangerous situation. I mean, this worked exactly how it should work for all the children in the state.
If you weren't here, what would things, you weren't here after before January, what would they have done?
Well, in that case, then they would put him on some medication that Dr. Williams discussed, the prostaglandins, and they would have stabilized, and then he would have been transferred likely to Texas to a heart center there to have the surgery, which is a huge inconvenience, and there is some risk associated with that to the child, and some of the inconvenience also is that mom is sometimes here recovering while their baby's having surgery, and dad's there, and then we have another child who's taking care of that child, and what family do they have around and friends do they have around at that hospital. So this is the way to do it, and we're fortunate to have this system now.
I know you joked about not stopping, but the clock is ticking as soon as the baby goes on bypass, correct?
Correct.
And so you have to work efficiently and have your roadmap and know exactly what you're doing. I mean, I know things don't always follow the map exactly, but you really go in with a plan, correct?
You're right. We go in with the plan and then a couple other plans just in case we run across some other things. The coronary arteries can sometimes not be right, a valve cannot be functioning. So you do have to have backup plans, but the length of an operation and how long the heart is stopped correlates to the outcome. So you have to be efficient and do it quickly, but you don't have to do it so quickly that it doesn't look great, because what you want to avoid is having to do something over. So time is a big deal, but I think even more important, doing it right and having a backup plan is a bigger deal.
How does it feel when you see this bright, pink, happy, normal baby in the room with you?
Oh, it's wonderful. That's the best part of the job, and that's why we do what we do. It's heart-touching and incredible.
So we always have a scar, kind of a reminder of the miraculous beginnings.
Yeah, I'm not going to be able to change that right now, but if we come up with the technique,
Small price to pay.
that's right.
Dr. Williams, will you talk about the importance of prenatal care?
Oh, I've done a couple of these before, and I've always stressed just the importance of prenatal care, because in situations like Whitney said, she came in and it was supposed to be a routine ultrasound from her obstetrical provider, and she wanted to know the sex, and without that ultrasound, just think about it just for a second, without primary care, had Whitney not been able to seek care and present it to our labor and delivery, or worse yet, a labor and delivery that didn't have a tertiary care system in place, or a pediatric cardiothoracic surgeon, it could have been potentially devastating and catastrophic for the family. And so I can't stress enough the importance of prenatal care. It allows for us to perform baseline testing, and not to mention anything out of the ordinary we can take care of sooner rather than later. Prior planning prevents poor performance is kind of what we, one of our mottos here. So I like to know in advance. I don't like surprises.
Any other questions? All right, well, thank you all for joining us today. We really appreciate it.
Thanks. All right.
Good job. Well, now they're going to come over here and they're going to